All right, if you're gearing up for your medical exams and really need to nail down GI endoscopy, you are in the right place. We're about to run through the absolute must-know, high-yield facts on everything from the tech to critical clinical pearls. So let's just jump right in.
So here's our game plan for today. We're going to start with a look back at how endoscopy evolved, then we'll break down the tech inside a modern scope. After that, we'll cover the safety rules you just can't mess with, see how it all works in real clinical situations, and finally, we'll check out some of the super advanced techniques. Let's get started.
Okay, let's kick things off by putting your knowledge to the test. Here's a classic exam-style question about the history of endoscopy. Let's see if you know this one.
So who was the brilliant mind behind that very first model of a flexible fiber imaging device way back in '54? Was it
Option A, Basil Hirschowitz, a huge name in gastroenterology for sure.
Or was it B, Larry Curtis, one of his partners?
How about C, Harold Horace Hopkins?
And last but not least, D, Hans-Gerhard Creutzfeldt. Go ahead, lock in your answer.
And the correct answer is C, Harold Horace Hopkins. Now listen, this is a classic exam trap, so you've got to remember the difference. Hopkins created the theoretical model in '54. It was actually Hirschowitz and Curtis who took that idea and built the first working flexoscope a few years later. It's a subtle but really important detail.
And this timeline just shows you how fast things moved. I mean, think about it. In just 25 years, we went from literally squinting through bundles of glass fibers to seeing these beautiful digital images on a screen thanks to the CCD endoscope. And by 2008, with endomicroscopy, we could do what's basically a real-time virtual biopsy. Each step was a massive leap forward.
So what is the magic that's happening at the tip of a modern endoscope? Let's dive into the technology that took us from a blurry eyepiece to crystal clear HD monitors.
You know, the hero of this whole digital revolution is this little thing right here, the charge-coupled device, or CCD. It's just a tiny chip at the very end of the scope that acts like a miniature camera. It's what turns the light it sees into a digital signal. This is the component that meant we could finally stop squinting through an eyepiece and put the image up on a big screen for the whole team to see. Now, this is where it gets really clever. We've actually combined the endoscope's camera with ultrasound technology. These are called echo endoscopes. They have a tiny ultrasound probe at the tip that sends out sound waves, which lets us see through the wall of the stomach or the intestine. This way, we can check out deeper things like lymph nodes or the pancreas, stuff a regular camera could never ever see.
Okay, let's move on to some absolutely non-negotiable safety rules. You want to pay close attention here because decontamination and patient consent are always high-yield topics on your exams.
All right, another critical safety question for you. Imagine you've just done a biopsy. Which condition would make you literally have to take that endoscope out of service and quarantine it?
The answer is variant Creutzfeldt-Jakob disease. And why? Well, it's because the infectious agents, these things called prions, are unbelievably tough and resistant to all our normal cleaning methods. So to completely eliminate any risk of passing it on, the scope just gets quarantined, a super important safety fact to have locked in.
Now, for every other procedure, this 4-step cleaning process is basically gospel. Step 1 is manual cleaning, right at the bedside to get off all the gunk. Step 2 is irrigation, a super deep clean where every single channel is brushed and flushed out. Step 3 is disinfection, soaking the scope in a powerful chemical to kill anything left. And finally, step 4 is drying. This is so critical. You have to blow compressed air through all the channels, because any moisture left behind can grow dangerous biofilms. You can't skip a single step. Here's a number to burn into your brain. When you're consenting a patient, at what point does a risk become significant enough that you absolutely have to mention it? The threshold is 0.5% or 1 in 200. Remember that.
Okay, so we've covered the how. Now let's get into the what. We're going to apply all this knowledge to some common and pretty urgent clinical scenarios that you are definitely going to come across.
This is a massive treatment principle for upper GI bleeds you just have to know. If you see a bleeding peptic ulcer, injecting adrenaline is a great first move to slow things down, but it is never enough on its own. You have to follow it up with a second method, like using heat to cauterize it or putting on clips to stop it from rebleeding.
Wow, okay, this slide is pure gold for your exams. Let's break it down. First, for esophageal varices, band ligation is the standard of care now, mainly because it has a much lower risk of rebleeding than the old sclerotherapy. Second, for what we call watermelon stomach, or GAVE, The go-to treatment is argon plasma coagulation, or APC. It's the safest because it burns the surface tissue very precisely without going too deep. And finally, if you have a patient with a big GI bleed who's on blood thinners, you have to get their INR below 1.5 before you can safely do any endoscopic therapy.
Finally, let's touch on some of the more specialized procedures and the cool technology behind them. These are the kinds of details that can really set you apart.
This is such a classic exam question: radial versus linear echoendoscopes. Here's the absolute simplest way to remember it. Radial gives you a full 360-degree panoramic view, which is perfect for diagnosis. Think of it as being for looking around. Linear, on the other hand, has a forward view, kind of like looking down the barrel of a gun. That design keeps your biopsy needle perfectly in line with the ultrasound image, which makes it ideal for interventions like a fine needle aspiration. So just remember, radial is for looking, linear is for doing.
Let's wrap up with 3 rapid-fire crucial facts. 1. With capsule endoscopy, you can never give it to a patient if you know they have a narrowing in their small bowel. Why? Because that capsule can get stuck and cause a serious obstruction. 2. Before an ERCP, giving rectal indomethacin is standard practice. It helps prevent the most common and scary complication, which is pancreatitis. And 3. During a colonoscopy, how do you prove 100% that you've reached the end? The gold standard is to actually pop into the next section, the terminal ileum. That's the only definitive proof.
You know, when you think about it, we've gone from these blurry bundles of glass to digital chips and now even microscopic imaging, all in just a few decades. This field is always pushing the limits of what's possible. So the question for your generation of doctors is this: what's going to be the next huge leap in our ability to see, diagnose, and treat from the inside? Thanks for joining me.